Hi there, we are discussing hyperkalemia. Hyperkalemia is defined as a serum potassium concentration of more than 5.5 milliequivalent per liter. As with low hypokalemia, hyperkalemia can result from transcellular movement of potassium out of cell or from alteration in potassium intake or excretion. In hospitalized patients, hyperkalemia is frequently the result of iatrogenic potassium loads or overcorrection of hypokalemia. Let's discuss possible causes of hyperkalemia. So one of the regulable mechanisms represent kidneys, and if they fail to work, like renal failure, so potassium accumulate. Acidosis with shift of kalium with hydrogen. Kalium inside and hydrogen out of the cell for correction of this. Rhabdomyolysis, which produce destruction of the muscles and eliminating kalium and many of the other metabolites. Succinylcholine increased by 0.5 at one dose administration in bolus of milliequivalent of potassium in the blood can increase to these values. Increased potassium intake is not so often an overcorrection of hypokalemia, and even taking a sample of the blood at the catheter site. At the catheter site, if you are taking blood from this one or from this arm and of the portion, and in the blood vessel, especially vein, could be some high level of potassium, which is administered. How about signs and symptoms? So they depend on the acuity of the increase of potassium. Chronic hyperkalemia is often asymptomatic, and dialysis-dependent patients can withstand with considerable variations in sodium potassium concentration between dialysis, usually 2 to 3 days between dialysis, with remarkable few symptoms. So chronic hyperkalemia may be associated with non-specific symptoms such as general malaise and mild gastrointestinal disturbances, and more acute or significant increases in potassium in serum potassium manifests as complication of change in membrane depolarization and neuromuscular and cardiac changes, which they are contributing for metabolism, including weakness, paralysis, nausea, vomiting, bradycardia, and asystole even. How you diagnose hyperkalemia? Of course, taking blood sample, vein blood sample, or even arterial, if you have access or would like to produce to make a arterial puncture. So you are taking blood sample, you are making one EKG, and you can see some variations like peaked T waves, or prolonged QRS complex, or disappearance of P wave. So they are common signs and symptoms of hyperkalemia. You should suspect on diagnosing first if there is not administering too much kalium, or if there is if they do not have appearance of any of the hemolysis, erythrocytes or thrombocytes or even leukocytes. So destruction of the cell liberates some potassium in the blood and increasing level. What is the treatment of hyperkalemia? Immediately you should administer calcium chloride or calcium gluconate intravenously, of course, because they are protecting cells, especially cardiac cell. Insulin with or without dextrose, especially glucose, 5 or 10% glucose, with insulin as a buffer system, which makes this cellular shift of the kalium and glucose together, which promotes this absorption and assimilation of glucose by cell. Sodium bicarbonate, which produce alkalosis, and again going to this shift, hyperventilation, alkalosis. So these two are for alkalosis. Alkalosis which promote and contribute to the cellular shift of the potassium. Loop diuretics are treatment for if kidneys are working at least oliguria, if not anuria. Sodium polystyrene sulfonate or kayexalate are given per oral, and this drug prevent absorption of potassium. This doesn't work rapidly and is used in some of the intoxications or drugs that can be absorbed in the intestine. And dialysis, most useful treatment of, and the last one in treatment again against potassium. Also important points represent avoiding drugs that increase potassium like succinylcholine or potassium-containing solutions like lactated Uringer or Normosol. Thank you very much for your watching and hope this video is useful for you.